So, warning. The only reason I ever agree to fly across the country, to take a half an hour to make a jackass of myself in front of a room full of smart people, is I have a mission, which is to get more support for FIRST. Daniel says, you can do that, but you first have to earn it by talking about what you've been doing at DECA. And then, since we're about NextMed, what you're going to be doing in the future. And then you got to talk about Army, because it's so, I think, important to the evolution of medicine that's happening very quickly, and you've heard about that all day. So I tried to put together something that covers those three things. DECA, Army, and FIRST. That gives you 10 minutes for each now, 9 minutes for each. And there's more than 4 decades of DECA. I've got about 1,000 engineers, and we've been making medical products for lots of big companies for a long time. Most of the people don't know where our technology is because we license it to big guys. We have over 7,000 patents. Then I've got over 3 decades of FIRST, with now more than 82,000 schools. And then a few years, almost a decade, of Army. But as you heard from Jennifer McDonald this morning, it's got more than 200 member organizations, and it's doing incredible things. So the only way I can possibly cover those 3 things in 27 minutes was I tried to put together a few short pieces of videos that they've each used over time. I've realized, since they're only snippets of videos, they'll probably be as incoherent as I am. But if there's 3 minutes or 4 minutes of videos related to DECA projects, 3 or 4 minutes related to Army projects, and 3 or 4 minutes dedicated to FIRST projects, that gives me 2 minutes to really talk fast about it. So I'm going to start with just an overview of the iBot stuff, or the DECA stuff. Again, Daniel asked me to throw an iBot in my plane. I brought it out here. I hope you all saw it. We're very proud of it. That's the 3rd generation of those machines. We just got the FDA approval on the newest one that even allows for tilt and recline. And it only took another 15 years, but last year we finally got CMS to give it an actual code. They finally realized an iBot is not a wheelchair. Anyway, I have about a 30-second video of it in places doing what I couldn't show you. But it climbs over everything. And yes, you saw it do that. It stands up. And yes, it climbs stairs. These are all real users. And it gives people their life back. And by standing up, it gives them their dignity back. And it's something that we're very proud of. Yeah, that's called snow for most of you people that live out here. Anyway, we're very proud of it. It's probably, when it came out, the most sophisticated fly-by-wire Class 3 medical device or robot ever made. That was 20 years ago. The newest ones are still 20 years ahead of their time. Nobody seems to really focus on the needs of the disabled. But we decided to make a newer, simpler version for people that maybe just don't want all the issues and problems of particularly the stigma of wheelchairs. So we made this is a seated version of the Segway. By the way, the iBot came before the Segway. The only reason the Segway was seen sooner is it took 3 years to get the FDA to approve that iBot. This thing we just launched this year. Now we're going to go to, as Daniel asked, what we're doing now. Well, this patent expired. We had a little party a couple of months ago. On January 7th of 1975, I got the first patent on a wearable insulin pump. That's my thumb, 50 years ago. 50 years ago. We've come a long way since then. I stopped making those things for probably 40-some-odd years until we realized that closed loop was going to be real. The sensors are now awesome, but they give you information every few minutes. A mechanical pump can't keep up with that. So a few years ago, we decided we're going to make a new one. It's completely solid state. It has no motors. It delivers plus or minus a couple of microliters per pulse using a acoustic volume sensing that we invented to make this puppy work. There it is, and it talks to your sensor and it talks to your phone. We got it approved a few months ago. The first ones went on people a few days ago, and it's already been written up in a couple of major, like the IEEE journal, compared to all the other mechanical pumps, including my old ones, so I have to be kind to those old mechanical pumps, but they're like adding machines. This thing is like a calculator. This is in that article, and as you can see, occlusion detection 5 to 22 times faster. Well, if you have to wait 22 times as long as a few minutes it takes to know that you're not getting your insulin, you got a problem. Anyway, we're very excited about this, and we think it's going to really help the world of people like my brother with diabetes. It's funny that a few people mentioned nurses, and this one will seem, I think, to any of you that haven't spent time in the hospital, or certainly people that haven't had to deal with drug delivery systems, this is not going to seem like a big deal to any of you. We're so used to those 10 or 15 pound boxes that sit by the bed. The IV bag comes down, the set runs through them and off to the patient. Sort of the one thing that that pump was there for was to make sure you could accurately administer. But in order to do it, it either peristaltically or by some other means pushes the fluid. Now that you're pushing and pumping that fluid through this rigid, the pressure you can develop is very high. The fact that air can be pumped is a problem. It's sort of like they solved the one problem, make it accurate. But the price they paid for that is like a bunch of engineers decided that the easiest way to fix your pipes when they freeze is just put them on the outside of your house in the first place. They've created more problems than they've solved, and it's well known. The FDA knows the most dangerous piece of equipment in a hospital are these pumps because of free flow, because of all sorts of things. I don't need to go into it, but you probably wouldn't appreciate this if you didn't know that they are the most dangerous thing in a hospital. We finally decided, what's wrong with the little bag? Gravity, no high pressure, air doesn't travel down by itself. Eliminate all the problems by not even having to solve them. Make multiple channels talk to each other. So again, if you're not a doctor or a nurse, you'd appreciate, what do you mean piggyback set, secondary line, make this bag higher, make that bag lower. When you're giving this drug, turn this one off. When you're doing that, turn this one off. It's unbelievable, the nonsense that they've expected nurses to be able to. You got a patient that's in trouble, and you better be really good at hydraulics and hydrodynamics to make all of it. Anyway, we decided that we should use AI and high-performance cameras. We should look at that drop forming, volume of a drop, a sphere, 1/4 pi r cubed. Look at the size. You can calculate it in real time. You can control it using just gravity. And we should make it small and light. So we made a little device, and we said we can hang it on the pole. In fact, you just hang it on the bag. I don't know if this is going to play. No? Can somebody play that? Maybe not. Anyway, we made a device, and we just got it approved. They're out in the area outside. You can play with them. It weighs less than half a pound. It hangs on a pole. We've shown it to major groups of nurses from all the biggest hospital groups in the country. And the only question they have after you show them this thing is, when can we get them? I wish I could show that 2-minute video, but maybe. HemoCare. I spent about 20 years building and updating, and we just got a couple of new ones out. Peritoneal dialysis machines. We have over 400,000 of them in the field now with our partner Baxter. They've shipped over 1 billion therapies for these things. It's essentially the worldwide standard for peritoneal dialysis. But soon after it came out, we realized that less than 10% of the world's end-stage renal failure patients can use peritoneal dialysis. They still need the old gold standard of hemodialysis, which is very invasive. And if you're not monitoring it, or if you don't have a machine that monitors it in real time, it's very dangerous. But it was so compelling to me that home peritoneal dialysis was giving people just freedom and access. Everybody that unfortunately is end-stage renal failure, but fortunately were amenable to peritoneal wanted it. I said, we just got to do that for the other 90%. We were told we'd never be able to do it because it would be so dangerous to be a self-administered therapy. We said, not if you make the machine really smart and you develop and invent sensors in it and you make it be able to make its own US Pharmacopoeia grade water out of tap water, because you need a couple of 100 liters of that a day, which you don't need for peritoneal dialysis. Anyway, we made it. And late last year, after 8,000 complete therapies on more than 50 patients in a completely, the FDA has got no sense of humor. We did a full clinical trial, 8,000 therapies, not a single adverse event as a result of a machine malfunction. The machine on top there is the dialysis machine. The thing it's sitting on will make US Pharmacopoeia grade water out of your tap. Here's again about it. If this plays, maybe it won't.
Introducing HemoCare.
This
an
was done by our
investigational
partner.
at-home hemodialysis system
And
that is designed to automate many setup steps to make it easy and safe for patients to self-administer treatments. Setup is expected to take patients as little as 5 minutes.
they made this
And it will
video
include
to
built-in
convince people to
safety
get into
features
the trial.
intended to reduce risk.
That's actually a nurse
take a look at
doing
some of the
the
features.
demonstration.
HemoCare,
This is 2 minutes
developed
of
with
about a
patients
half an
in
hour
mind, doesn't
piece.
look like a medical device when not in use.
But
And
it's there to show how easy it
tablet with animation.
could be done. And after the first 1,000 treatments were done in centers under supervision of clinicians, the other 7,000 were done by patients, by themselves, to demonstrate that you could do long nocturnal therapies. The machine would self-sanitize itself when you took those lines out of the patient and plugged them back into the machine. That's showing electrical signals we send into the patient so that if the lines do come out, it instantly turns off, which doesn't even happen when you're in a supervised environment. Anyway, we're excited that this thing just got approved. So we're not doing trials anymore, but we have a number of major clinical situations developing where we will be doing pilots. Here they're showing you could put even the heparin in there with no extra lines. Again, if you're not a clinician, you might not appreciate how significantly that improves what's going on. All of you that are worried about the disparity in care in this country, the poster child for what's wrong with how we do healthcare in this country is probably dialysis. It's a rare compared to cancer or diabetes or heart disease, yet it's about $100 billion a year, 1.5% of all patients that are getting Medicare, Medicaid, CMS services, 1.5%, but it's almost 20% of the whole healthcare budget. We spend well over $100,000 per year per patient giving them this very invasive therapy, 3 hours a day, or 3 hours of treatment 3 times a week. That's not enough, and it's not frequently enough. So at least, although we spend more than twice as much as most of the industrialized countries in the world on these patients per year, you should know we have the worst outcomes, by far. Shortest lifespan, most miserable life. If we can get them home and let them do their own therapies, the costs will go down, the quality of life will go up, and we're planning to get these machines out there as quickly as we can. And if I could make this thing work, I'd know what's coming, but I can't. Caspian. So that water machine I told you under there, I like to reuse our technology whenever we can. iBots became Segways. That water machine can go into a cabinet. Again, you may or may not know this, but among the many shortages this country is facing because we have offshored everything, even what would be considered a trivial commodity, a bag of IV solution, those 1 liter bags you see everywhere. The shortage of those after the hurricane took out the largest plant in Puerto Rico, and then a few months ago, you might remember, North Carolina lost another one. The shortages of IV solutions are so bad that most of the major prestigious hospitals in this country have canceled all elective surgeries because they don't have access to IV bags. So we took that little device, we talked to some of the folks in different pieces of government that need it, including the DOD, and we said, why don't we make a vending machine, essentially, that looks like a giant Coke machine. Maybe this one will play. And we will manufacture bags of IV solution in real time in the hospital, in the pharmacy. You'll never need to ship this water all over the world. That's the only thing that's a sterile piece of the environment. We completely automated it. We have oversight with cameras looking at every aspect of producing the water, filling the thing, sealing the thing. Here we're looking for microparticles in the bags, which they can't do, and they batch sterilize the stuff 1 million bags at a time. We've got a couple of these things. We've promised the FDA that we would have one complete machine delivered to them by the end of this year. And if we build a few more of them, it will make it really easy to eliminate any risk of shortages there. The US uses slightly over 1 million bags per day when they can get them. You've heard a lot about vaccines and lack of them, and some of the excuses people have, which is it's painful and people don't want to admit it, but they're needle phobic. In the midst of the COVID situation, we were informed, again, more by DOD than by HHS, that we've got to find a better way to give vaccines. And we were told, and you guys would know way more about this than I do, at least the clinicians among you, we were told, particularly for vaccines, where you really want those antigens, the vaccines, to go is into the skin, not into the, not IM, not sub-Q, not IV, intradermal, because your body puts all these things called dendritic cells. If you ask me what they are, I have no idea. But it turns out that it's been well known for 50 years that you have a higher density, 100,000 times higher density of dendritic cells in your skin than in any other organ in your body. That makes sense. Nature's pretty clever. If you want to put the guards between you and the outside world somewhere, you'd want to put them in the sea. If you put them, in your heart or your liver or your lung, like the cells there that are doing their job, putting those guard cells inside your body would be like building a parachute that automatically opens on impact. So we said, why don't they just give it that way? It'd be less pain. They also said, by the way, you need at most 1/10 the amount of the active ingredient if you can get it all directly into the skin. Some of these folks told us the only reason vaccines work at all is because you can't really get it through the skin and out without some of it touching those dendritic cells where you made the hole, and that's really the active part. So we said, we'll do that, until we found out that the depth of the skin that they're trying to penetrate is about 500 millionths of an inch. You got to get through the dead stuff, the stratum corneum, but not very deep. Well, I have the best tool makers in the world. You can't machine a part that freaking small with the hole and the bore and the diameter to be 100 millionths of an inch. You can't mold them, you can't machine them. But the semiconductor industry thinks that's big. I mean, they put 1 billion transistors on. So we went to the semiconductor folks, and we had to make super sharp little single crystal silicon needles, the backside of which we made a platen onto which we could bond a reservoir with 1/10 of 1 cc, basically a volume about the size of a baby aspirin. Put it into something like a Band-Aid, the reason we'll call it a daisy, that sticks to your skin, but when you push down like an orange peel on a table, it'll stretch the skin. So whether it's a little kid's soft skin or my rough old skin, the Band-Aid will stick. You'll push down until it makes a drum head underneath, and you push a little more, and you pop a spring, which adds a force to express this tiny amount of vaccine through these super sharp, tiny needles into the skin. You can't feel it. It feels like sandpaper on your skin because it's going 500 millionths of an inch deep. We made a little video to show what this thing works. I hope this video will work. This is a homemade video. Yeah, the FDA, I hope, is not watching this because it's not an official trial. The kid you see here is the daughter of the engineer that's sitting with her. But I wanted adults. I wanted kids. I have some of my engineers that are women. There he is, and there's his daughter. Some of my engineers are African American. Some are Asian. Some are old. Some are young. Some are men. Some are women. And so we just went around after we molded these things up, we manufactured them all, and we started putting them on people. And the fact is, now we're only giving them saline. They're being protected by whatever saline will protect you from. But the clinical community says we'll know it went into the skin if we have what they call a bleb. That's the little bump. If it went through the skin, you won't see a bleb, and if it leaks out outside the skin, now look at these blebs. And you'll see she didn't even feel it. There's the bleb, there's the bleb, there's the bleb, there's the bleb. Anyway, we now have built enough of these things that we have a number of companies that are making, there she is, that we have a number of companies that are doing trials now with new versions of vaccines. We're supplying these in small quantities, but our goal is that by the time the next time the world needs 8 billion doses of something, they'll need only 1/10 the amount we made last time. You can self-administer it. You don't need clinicians. You don't need needles. You don't need vials. You don't need syringes. And everything went dark. I hope it's not something I said. That's a manually fillable one in the field, and I'm running out of time, so I won't spend a lot more time on this, but we're very proud of it. I have some of them. I'll stick them on anybody that wants a bleb with saline. I happen to have one in my pocket. Right here, I'll peel it off and stick it on anybody interested. Army, you heard, again, I'm not going to say much then about Army because I have 7 minutes here. The Advanced Regenerative Manufacturing. Somebody asked this morning, why did we call it Army? Because it was the Department of Defense that gave us the first $80 million to do this. And since then, they've given us another $100 million. So I figured giving them a little recognition was a good idea. So you heard a lot more, again, from Jen McDonald, and she's credible. She's a doc. She was the most senior doc at a little place called the Veterans Administration, working directly for the secretary before we snagged her out of Washington. But we're making cells, we're making tissues, and we're making organs. And here's a version of cells. You heard about this. JDRF gave us money. At the time they gave it to us last year, all the researchers they're working with around the country, some of them may be in this room, or certainly the institutions are represented here, we're making Petri dishes at a time. 100,000, 150,000 cells would be pretty good, although none would ever come out exactly the same. They told us they needed millions quickly, then tens of millions, then billions. By the summer when we started building these fully automated systems, we were making a few million a day. By the end of the summer, we were making 1 billion a day. And I told my team we'd open a lot of champagne on New Year's Eve if we could make 1 trillion islets per day. We fell a little short. We're in the hundreds and hundreds of billions, but we will soon be opening champagne and be delivering well over 1 trillion of these cells per day. Then we made for another one of our members a device that takes a small amount of retinal material, and we'll take some iPSCs from that patient. The donor is the intended recipient. We put them in this thing. I hope it works. We built a little table model device that takes all of the media, takes everything you're doing with these cells, and makes a new little piece of this thing, which can be slipped in as easily as an intraocular lens, except it'll give you new cells so that all the geezers in this room that should be worried about macular degeneration leaving you blind will be a thing of the past. In the last stage of that automated system, it closes that flap, seals it up, and we can ship it around the country because it was manufactured and then sealed against the environment in the same device that manufactured it. And we'll be in front of the FDA with that pretty soon. This is a recellularized heart that we did for Doris Taylor a while ago. I don't know why it's not running. Then what if all of those organs, those cells, tissues, and organs start to really work? We realize we've got to be able to ship them around the world, certainly around the country. We need to build life support systems for individual organs. So back at DECA, which is literally in the same building, we put an extra room in the Army building next door for a group of my DECA engineers, and we took some of the same core technology in those dialysis machines and my other stuff and built this pod. This pod has a piece on top. That is a cadaveric kidney that was salvaged, put in there. We gave it life support. We've proven instead of the few hours they normally get where they got to rush it to a hospital and hope that docs make the right decision in real time and give it to a patient, we've run some of these now for 3 days, and they are healthier at the end of 3 days than they were at the end of 3 hours. So we're building pods, and we hope to get the FDA to bless those things pretty soon. With 4 minutes and 26 seconds, I'm going to go directly to the third thing that Daniel asked me to cover, which was, well, he said, you got to cover what's the future, Dean, because, you know, this is, I said, well, Daniel, you know I believe that in getting us ready for the future. But I said, I'm not going to tell them what the future of technology is, because whatever I say will be wrong. Every generation predicts how their technology will be used, and they're always wrong. And now with the rate at which you've already heard about all this exponential growth, all that means is we're all going to be wrong even more quickly than it's ever happened in the past. We're all going to be alive to humiliate ourselves instead of the next generation when we missed all of it. So instead of trying to predict for you what we are going to do as the next great thing, all the things you've heard about all day and all the things I'm telling you about are going to need really smart kids. They're going to take over, and they are going to continue the stuff that does work. They'll fix the stuff and the unintended consequences that we create in the stuff that didn't work. And so more than 30 years ago, I started FIRST. I'm going to show you now, since it's a 2-minute video that we've used for years. I hope many of you have seen it. But this is a 7-year-old girl narrating why FIRST is so important. Over and over and over, she's going to keep telling you, FIRST really isn't about robots. It's never been about robots. I didn't build FIRST so that we'd have more roboticists 33 years ago. I just used robots because they move, and you can make a sport. You can make it exciting, and kids love sport. And we got to get them passionate, particularly the kids that are grown up in environments where they never thought about science, technology, engineering, particularly girls. Now it's getting better. But this 7-year-old girl talks about it's teamwork. It's getting people. I mean, it's a future. It's curing cancer. And she talks about everything we talk about, and you'll see these kids in it, hopefully in a few minutes, and talk to them yourself. But she captures what we started FIRST to do and why it's so important that every parent, every government leader, every corporate leader ought to understand that we've got to make FIRST more available to kids all over the world. So here it is. Listen to a 7-year-old girl.
This isn't a robot. It very well may have hydraulic arms, a drivetrain, and a circuit board, but this isn't a robot. This is a lesson in humility, hard work, and collaboration. This is a CrossFit workout for the muscle upstairs. This is an apple for the next generation of Newtons. It's a lot of things, but this isn't a robot. This is a roadmap that leads straight to engineering. This is a rock to shatter 1,000 glass ceilings, a rope to pull a generation up and out of poverty, a sledgehammer to break down cultural barriers, and a universal language spoken in every nation on Earth. And because of that, this is a compass that can help point the way to peace. But please, don't think this is just a robot. This is Glastonbury for technology. This is mission control for the next moonshot. This is the Rosetta Stone to help translate the future. This is the sport that will help us win tomorrow. This is the software to program ourselves to cure cancer, build a clean engine, or step foot on Mars. But this isn't a robot. It's a machine to build the people who will change the world.
So first, and you'll all get one of these if I haven't given it to you already, it's our 2025 season. March Madness is just about over. This weekend there's events right around here. There's 182 cities holding events for 82,000 schools. We have 200,000 volunteer mentors. We'll give out about $80 million in scholarships at the championship, which you're all invited to in 2 weeks. I'll show you where it is. This is data done by third parties that talk about the fact that FIRST, year after year, has demonstrated to be by far the most cost-effective, efficient way to change kids' attitudes. This guy showed up at the championship last year where we had 50,000 people in Houston, and he has well over 10 million people that follow him. Great. Our championship again this year is in Houston, and write this down, it's in 2 weeks. It's April 16th to the 19th. About 1,100 teams out of the 82,000 from these cities all over will be at this championship. We take over the city. There'll be 55,000 of us there celebrating the future. If you want to stop watching the news and instead walk through a place and feel good about what you see. And just before he puts a hook in me, about 8 years ago, we realized that FIRST is having such a profound effect on all the kids we can reach. We've got to reach kids all over the world. We've got to bring the world together so the next generation of technologists that'll have way more power at their disposal than we've ever had better also have the right kind of vision and courage to use that technology as a tool and not a weapon. They learn in FIRST how to communicate, how to cooperate, how to trust each other. Let's get a network of kids all over the world to do that. So we started a sister organization to FIRST called FIRST Global. Now, it doesn't open up quite that big because it's only 7 pages long when I hand these out. You'll all get one of these too. But starting with Afghanistan up here and going to Zimbabwe, we have 196 countries. It took us a few years to get to that. But after we finished a year and a half, well, 2 years ago now, where we moved, it's just like the Olympics. It's one team per country. The United States had one team, so did Liechtenstein. So we've done it like the Olympics all over, and we had just finished one in Singapore, 22 hours from here. I'm going to make it easy for all of you to attend this one, because we finished that one 2 years ago, and everybody said, Dean, it is such a thinly veiled copy of the Olympic style, bring the world together. By the way, the Olympics has been going since 700 BC with the sole purpose of bringing the world together. Even in their world, 700 BC, every team that competed, 700 BC in Athens, you can't call them countries, but the nation states had to agree during the competition they would stop fighting with each other. So if anybody here wonders whether self-inflicted wounds can be stopped, it's like, could you stop hockey players from fighting? No, it can't be done. Anyway, we're in Singapore, and somebody said, Dean, you've proven it now. You have every country in the world. Put this thing in the right place next year. We put it in Olympic Stadium in Athens, and we'll show you, if they give us a chance during the reception, a video of the event in Olympic Stadium with 196 countries. This year, which is the 8th time we're doing it, it's not going to be an Olympic Stadium. There's my 196, well, that last year, 190 countries. And by the way, so that the kids don't forget, it's not about robots. This year, we put on stage for them, oh, I thought I had that picture. I made 2 giant tablets. There it is. They are 2 documents that I think are the 21st century need to accompany 2 existing documents in the US, but now to be global. The first set is called the Bill of Responsibilities. It's there to complement the Bill of Rights. And if kids don't learn to be responsible, for instance, to value truth, trust, fairness, the world's in trouble. The other document is a complement to another document we have in this country, and it's the Declaration of Interdependence, that every kid on the teams around the world has to recognize that in this global environment they're in, pandemics don't stop at an arbitrary line. Global warming doesn't stop whether you or your neighbor built that coal plant. So we asked every team from 196 countries, if you want to participate, one team member from every country that participates has to sign on behalf of that country a bill of responsibilities, how they respect and treat each other, and they have to agree to the Declaration of Interdependence. In the midst of the crazy world we have now, every country signed. So we said, where can we bring him next year after we went to, you have this iconic place in Olympic Stadium in Greece. Where do you follow that? Whether you want to believe me or not, I didn't jump on a news item. A few months after that, November, so in February of this year, we locked down a deal to be the next country to host First Global. You're all invited. It's much closer. We said, what could be as iconic as Olympic Stadium? Well, there's a little country that connects the Atlantic and the Pacific, the East and the West, the North and the South. We're going to Panama. Now, I open up news in the morning between Christmas and New Year's, CNN, and I see Panama. I'm such an egomaniac. I said, my God, before we made the announcement, it slipped out and it's all over the net. No, it was the president saying, we're taking it back one way or the other. And I'm thinking, I just got the whole world to send one group of kids to celebrate how they're going to work together and be into. So I don't know. There's a category of stuff that everybody knows. This shit only happens to Dean. And so people, after we made the announcement, we went to Washington soon after, earlier this year, January, and we used the OAS, the Organization of American States headquarters, which is right across from the Constitution Hall, right down the street from the White House, and all the representatives, the ambassadors from Panama, and we invited every ambassador from every country in the world. We had a fantastic unveiling. We're doing it in Panama. And it was so well received. I'm begging you, people. The news, the loonies that make the most noise on each end of the scale, we got to stop. We have to have the people that make sense, have a loud voice, especially a loud voice for the next generation of kids. If you're not willing to do that, if you're not willing to support first teams in every school, if you're not willing to support this global first thing, maybe we'll all get what we deserve. But I'm begging all of you, I'm begging you, the future, one way or another, is these kids. And they're growing up in a crazy environment where social media is turning them into extremists at one end or the other, that you don't want the world to be driven by this ping pong. We need, collectively, we need the smart people in the middle to become the loud voice, and it has to happen quickly. And there's only two quotes I love to use. One is Albert Einstein, and it's none of that heavy stuff. He is one of my heroes. I'm a physicist and a mathematician. I love. But near his end of his life, 1953, in his letters up and back with some of his colleagues, Einstein said, the only difference between genius and stupidity is genius has its limits. The other quote, which is more serious maybe than that, and it's been attributed to Edmund Burke and a lot of other people, is the only thing necessary for the triumph of evil is for good people to do nothing. You're good people. We've got to invest in creating a generation of kids that will stop the self-destruction that seems to be getting louder all the time. The world is in more chaos now than any time since World War II, but the power of technology is going to make it easier to even amplify the craziness. If you want all the successes everybody's been talking to you about to become realities, the technology's going to move. Don't worry, one way or another, it's going to move. But we better get the loudest voice among the most responsible young people to make sure that the control of it and the distribution of it is to make it a better world for all of us. If we don't, you can figure that out.
Dean Kamen. Shauna. As always.
On behalf of all the good that you have put forth in the world and all the good that is yet to happen because of your trailblazing ways, we are honored and blessed to thank you and give you this NextMed Trailblazer Award.
Thank you. Thank you, Doctor. Thank you. Thank you. Thank you.